Medical Dialogues. I am Dr. Nandita Mohan, and today I will be taking you all to explore the world of rare diseases. And my topic for today is pulmonary arterial hypertension. Now, to help us understand this rare disease in a little bit more detail, we have with us today Dr. Brajesh Kumar Mishra, who's a well known cardiologist at Manipal Hospital, Gurgaon. He has 24 years of experience in cardiology and has worked as an expert in different cities in India. Now, Dr. Brajesh also has contributed to handling numerous complex medical cases in several hospitals. He is known for his attention to accurate diagnosis and also for treating patients empathetically. Now, the specialty interests of Dr. Mishra are procedures like radial procedures, ICD, CRTD pacemakers, interventional cardiology, cardiac electrophysiology, to name a few. Now, he is also an active member of the Indian Medical Association and the Indian Heart Rhythm Society. So, welcome to Medical Dialogues, sir. It's really a privilege to be having you on board here with us today at Medical Dialogues.
Thank you. Thank you for giving me this platform. Thank you.
Great. So now you're talking about pulmonary arterial hypertension. If you could just explain to our viewers what is this rare disease and primarily why is it even categorized as a rare condition?
If you see pulmonary artery pressure, normally it ranges from 11 to 20 mmHg of the mean pulmonary artery pressure. If it is beyond 20, it is considered as pulmonary arterial hypertension, and this should be measured on right heart catheterization in resting position. And if it is elevated, it has shown that it increases the morbidity, mortality significantly, and there is a gradual linkage of mortality and mortality with the rising of the pulmonary artery pressure. Usually, if you see, the 1% of the global population is suffering with pulmonary arterial hypertension. But if you see the age beyond 65, it becomes significant. It's like 10%. And if you see the overall 80% of all those population are from developing countries, those population has less access to a proper medical care and medications. Obviously, therefore, this becomes a concern. As the age rises, the incidence of pulmonary arterial hypertension rises. But if you see in the Indian perspective, the left heart disease and the pulmonary disease contributes to the pulmonary arterial hypertension. Therefore, here, because of lack of infra and proper care, we are not able to detect some majority of the hidden cases who are really suffering with pulmonary arterial hypertension. In India, if we see the congenital heart disease, which is late detected, the underlying rising coronary artery disease with LV dysfunction, the diastolic heart failure and systolic heart failure leading to pulmonary arterial hypertension, this becomes the major cause, and in comparison to Western world, where the idiopathic pulmonary hypertension is the main cause of pulmonary arterial hypertension. Therefore, these diseases which are still undetected, if we will count it, obviously the data will become significant. Although that's why I think that this is not rare in our society with perspective of India.
Okay, understood definitely, sir. Now we're talking about this in a little bit more detail. What are the primary causes, or if I may highlight, the risk factors for pulmonary arterial hypertension, and are there any emerging causes that one should actually be aware of?
Whenever we discuss, the WHO has classified this pulmonary arterial hypertension into 5 subgroups. The one is idiopathic, which I was telling you earlier. It is in the Western scenario, this is the predominant reason. But in our world, when we know that underlying LV dysfunction, the poor heart pump functions, the progressive lung disease, the connective tissue disorders, the late detection of the congenital heart disease, this is like a major contribution leading to pulmonary arterial hypertension. If you see the demographic composition, that what are the causes of pulmonary arterial hypertension in Asian perspective, and from the Indian perspective, this changes, and these are still undetected. Even the progressive rise in the renal disease, connective tissue disorder, some HIV, also leads to primary pulmonary arterial hypertension, connective tissue disorders. These all are contributing to pulmonary arterial hypertension. It's not a single entity. WHO has divided into 5 subgroups. First is essential hypertension or idiopathic pulmonary arterial hypertension. Then the second group is because of the left heart failure, either systolic dysfunction or mitral valve disease, or a diastolic dysfunction or diastolic heart failure, and other causes which leads to increase in the pulmonary venous pressure, ultimately leading to pulmonary arterial hypertension. And third subgroup is related to lung disease, the pulmonary fibrosis, the restrictive lung disease, interstitial lung disease, chronic obstructive lung disease. And fourth subset is pulmonary embolism, thromboembolic event continuously leading to rise in pulmonary arterial hypertension. And fifth subset is a miscellaneous group. Therefore, this is not a single entity. This can be divided into 5 subtypes, and every disease is contributing to pulmonary arterial hypertension, and they have a diverse etiology and mechanism.
Yes, that's very well explained, sir. We can actually categorize the causes into 5 subtypes, as you mentioned. Now, what are the early symptoms of this disease, and how can patients actually differentiate them from other heart or lung conditions? You mentioned that the various subtypes, and the third one you even mentioned as lung disorders or others. So how can one differentiate between the symptoms about from these diseases?
The symptoms are very from if you see when the patient is coming to you first time, the symptoms are very vague. The symptoms are like a early fatigability, like a breathlessness, exertional breathlessness. Patient is not comfortable in walking, or if disease progresses gradually in the in the late presentation, can be a florid heart failure, right-sided heart failure. There is some swelling in the limbs, the fatigability, the collection of fluid in the abdomen, liver enlargement. All these can be, or a frank blackout can be a presentation, but early manifestation is very vague. And as we know now that this is a group of disease which leads to pulmonary arterial hypertension, the initial picture of PH will be like a fatigability or a exertional dyspnea or breathlessness. But when you see, there will be other associated symptoms of a specific disease, like a connective tissue disorder, when patient will present as a joint pain, limb pain, some embolic event, some connective tissue disorders, some parasitic infection. It may happen because of the HIV. Patient may have a symptom of HIV also. Sometimes this may present as breathlessness because of the heart failure, and you primarily focus on the heart failure. Obviously, when you deal with, and when we will come to know about the treatment, we know that all these subsets we need to treat the specific disease also. Therefore, the symptom to begin with is just a breathlessness which comes on exertion, or a mild swelling in the feet, or a very slow progression of the disease initially. And that becomes a catch point, that these patients you will find very commonly in the OPD, that I feel breathless when I walk. But that is the thing, when you have to consider this, that this patient may be a patient of pulmonary arterial hypertension, and you need to think about this when you evaluate the patient.
Okay, definitely. Now, sir, how common is pulmonary arterial hypertension, and which major population, or are there any specific number of people who are at risk of developing this condition?
Basically, whenever you are seeing any patient of PH, you have to think of all these differential diagnoses. That we have classified this pulmonary arterial hypertension as 5 subcategories. And whenever you are seeing all those patients that coming with a breathlessness, or a general fatigability, or a early fatigability with a mild swelling in the feet, these patients you have to think about that there is a possibility. And if you work up those patients for other viral markers, for other connective tissue disorders, for other association like a lung disease, like a kidney disease, you then if you have these problems and you are coming with these symptoms of heart failure, obviously then you have to think of the possibility of a pulmonary arterial hypertension. And if you are having these disorders, you have to get evaluated by a cardiologist. That is there any possibility that you are having symptoms and you are suffering with a pulmonary arterial hypertension? And if you detect early and if you are treated early, this increases the longevity of the patient.
Okay, now, so coming to the next aspect, the diagnosis part. So, how is it diagnosed, and what tests or any clinical procedures that are typically used to confirm the diagnosis of pulmonary arterial hypertension?
As discussed earlier, that patient comes with breathlessness, fatigability, and if this is so, then when you are seeing the patient, first thing which you do is you ask for an ECG or an echo and a few blood tests. The ECG, if there is like a involvement of the right side of the heart, you will get some changes in the ECG consistent with right heart involvement, like a right bundle branch block or right ventricular hypertrophy, right atrial enlargement, these kind of thing, or a P pulmonale kind of thing. Sometimes in the echo you get a TR, tricuspid regurgitation, you get a high pulmonary artery pressure, you get a RV dysfunction, and then after that you see these findings which may be consistent with pulmonary arterial hypertension. You think about the other disease and possibilities that may contribute to pulmonary arterial hypertension, like you look for evidence of heart failure, you look for NT-proBNP in the blood test, you look for anemia, you look for ABG to see whether the lung is culprit, hypoxia is the culprit, how much is the carbon dioxide, what is the lung condition. You look for X-ray. In X-ray you get a right heart enlargement, and then subsequently when you get all these things, if there is any history suggestive of veno-occlusive disease or a thromboembolic disease, you look for CTPA, if there is any clot formation in the lung or not, then MRI can contribute. But ultimately, if you see all these investigation, the final confirmation of diagnosis comes with right heart catheterization. And in the right heart catheterization, you have to show that this pulmonary artery mean pressure is more than 20, and that confirms the diagnosis of pulmonary arterial hypertension. But if the patient has a minimal breathlessness, like a mild edema, like a mild breathlessness on exertion, or a mild swelling of the feet, it's very hard to convince the patient for the invasive cath lab evaluation and the right heart catheter.
Very well said, sir, because it all actually comes down to early diagnosis. So if the patient presents with early symptoms and you come to a diagnosis, confirmatory diagnosis, then convincing the patient to actually get it diagnosed early, it definitely becomes a challenge. Now we spoke about the signs, the symptoms, the most common population that usually is at risk, the diagnosis part. Now coming to the next aspect, which is the treatment part. So what are the current mainstays for treatment, and how do you think they work to alleviate the symptoms or even slow down the progression of the disease?
Most important thing that we don't have, unless until there is definite cure, like you are suffering with a LV systolic dysfunction, you are suffering with some left valve disease which requires intervention, and if you do and the PA pressure is released. But if you see there's idiopathic pulmonary arterial hypertension, in those cases you don't have a real cure. You give medications to optimize the symptoms and increase the longevity of the patient. Obviously, when we see that patient is having this problem, there are three important mechanisms which produces vasoconstriction and enlargement of the pulmonary artery musculature. There is growth of the endothelium, the inner coating of the pulmonary artery, and you hit those specific pathways. And we know that there are, if you see the etiopathogenesis, you see there are nitric oxide mechanism, there are prostacyclin pathways, there are endothelin receptors, cyclic GMP pathways. These are specific pathways which leads to all these manifestation of vasoconstriction of pulmonary arteries and proliferation of endothelium, leading to occlusion and narrowing of the pulmonary artery, which ultimately leads to RV dysfunction or strain on the right side of the heart. Therefore, whenever we treat, we target those specific pathways. Like in prostacyclin, there are certain drugs like epoprostenol, treprostinil, iloprost, and latest selexipag. And if you see nitric oxide mechanism, obviously cyclic GMP mechanism is taken care of by the riaciguate. We use this drug when the first line drug is failing, then we use riaciguate. And if you see endothelin receptor blocker, we have a bosentan, macitentan, ambrisentan, and obviously then the vasodilator like phosphodiesterase inhibitor like sildenafil and tadalafil. And usually we start treatment with combining two initial medications. If you feel that these patients are high risk, then you add on as a third drug like a nitric oxide mechanism riaciguate, or like a prostaglandin analog selexipag. This is usual approach for treating a pulmonary arterial hypertension patient.
Okay, well, very well categorized and explained, sir. Now, you mentioned the various drug formulations. You mentioned that it's basically symptomatic treatment also should be the one of the mainstays for treatment aspect. Now, are there any new or any emerging therapies that are showing promise in its treatment, and how will we compare them to the existing treatment options that are already available for treating pulmonary arterial hypertension?
If you see from the 2007 onwards, we have so many medications. Earlier there was very little medications, and the new emerging evidence is with a new drug, that is activin signaling inhibitors like sotatercept, as well as like a few medications like tyrosine kinase inhibitors, imatinib, as well as a few other medications. These drugs has shown some promise and is showing a significant improvement in the NYHA class and the RV functions. Therefore, these are new molecules which are coming in the this management part, but we will have to see what is the long-term effect of these medications. But obviously, this sotatercept is a newer drug which has shown a promising result in the subset of patients.
So, what are the biggest challenges when you're treating patients who are suffering from this disease, and both from a clinical as well as a patient perspective? If you can elaborate on the discrepancies or the challenges, the biggest challenges that you have encountered overall in your experience so far.
As discussed earlier, I told you that whenever patient comes to you with the minimal symptoms, it becomes hard to convince the patient that you are having a disease which is just a breathlessness on exertion, but which has a long-term implication that you need a confirmation of pH by right heart catheterization. It's very difficult to convince the patient for that. And if you find, obviously, for the patient, it's very difficult to accept that patient has to be on drug lifelong. And we need a intermittent optimization, addition, and further management like supportive care by giving some iron therapy, some diuretics to optimize the symptoms, as well as once the disease, we know that once there is evidence that if the PA pressure is high, there is a linear correlation with the mortality. But for patient, this is very difficult to accept that he came to a doctor with a minimum symptom of breathlessness and he is finding that this disease is not curative. This is the most difficult, as well as if you see from the organizational aspect in India, we need to make a system where the all PH patient care should be standardized, and the clinician must be aware about how to approach about the PH patient for a good care of the subset of patient.
Yes, definitely, sir. We all need to create awareness. So that is the main aim that we're doing with this video of yours. Lastly, sir, I would like to ask you, what do you think is the most critical factor in improving outcomes for patients with PAH?
The thing is that early detection. Early detection is the most important part. If you treat early, intervene early in the course of the disease, the patient is just, if you see the functional class, which we say that breathlessness on almost normal patient with a mild breathlessness, if you will intervene at this point, this delays the progression of the disease. Therefore, the disease should be detected early, should be given optimal treatment and should be reviewed time to time so that this retards the progression of the disease. And the second most is that give hope to the patient. There are so many things which is coming in this way, as I discussed, that activin signaling inhibitor, like I told you earlier, that sotatercept, as well as there are certain things like this is known as endothelin colony forming cell. This is a stem cell therapy. If you give this improves the RV functions, this improves the PA profile of the pulmonary arterial hypertension patient significantly. But these are the research subject areas. But we probably in next few years we are going to see this coming in a big way.
Very well said, sir. So, thank you so much, Dr. Brajesh, for joining us today at Medical Dialogues and giving us all the valuable insights about pulmonary arterial hypertension. I am pretty sure this is going to create awareness among the medical professionals to actually come down to encourage patients to have an early diagnosis so that prompt treatment modalities at the earlier stage can be advised. So, thank you so much once again for joining us today at Medical Dialogues.
Thank you. Thank you very much.
Never miss a medical update from Medical Dialogues. Like, subscribe, and press the bell icon.